Hello, everyone, and welcome to Nothing Pink. We are here tonight at the Roots, and we have Dr. Robinson, a plastic surgeon, that is going to talk with us about what are the options for breast reconstruction after a mastectomy. So, thank you so much for being with us, Dr. Robinson. I'm going to bring this over to you now. There we go. Okay.
Well, I'll look down here occasionally.
Yeah.
Welcome everyone. So I'm Dr. Robinson. I've been here in Charlotte for, I guess, 16 and a half years now. I came here from Charleston, South Carolina, from the Medical University of South Carolina. I did a lot of my training with Dr. Klein and Dr. Craigie down there, who I think are also big supporters of the pink out. I mean, nothing pink. Sorry about that.
I'll edit it.
My goodness.
It's okay. It happens.
Oh, it's so yeah. So they're wonderful guys, and they were excellent mentors for me. And so I moved here from there. When I came here, there was no one doing tissue-based reconstruction. So that's why I do have a large practice of doing deep lapses, because at the time there was no one else here. So that's where that all started. But my practice is probably 95% breast reconstruction. So that's pretty much all I do with plastic surgery. I don't do any cosmetic surgery. It's pretty much all breast cancer. I do some breast reductions, and then I do some facial trauma, but it's mainly just breast cancer, breast reconstruction. So when I speak to a patient about breast reconstruction, I tell them, start off and say, basically, you have three options after a mastectomy. Okay. And so I'll basically go through mastectomy reconstruction. If someone has questions about lumpectomy and options with that, I'm happy to answer questions with that as well. But I tell them, three options. One is no reconstruction, being flat. And then the next two options are implants and tissue. Going through the two options of implants and tissue, I think they're both good options. Both of them work well. They just have different advantages and disadvantages. And it's evaluating those advantages and disadvantages to see what works for individuals. I would say that overwhelming majority of people are candidates for both. And so it's really comes down to evaluating those differences to see what works best for each individual. So going through those two different choices, the first option we can say would be implant-based reconstruction. And the advantage of implant-based reconstruction is it's a quicker operation, quicker recovery, and adjustable size. And so basically, for the most part nowadays, most implant-based reconstruction is now done above the muscle, or what we would call pre-pectoral. And so that means is that the tissue expander implant are placed on top of the muscle, and then we cover the implant with what's called ADM, or acellular dermal matrix. And it's basically just a sheet of collagen. And the purpose of that is just to separate the implant from the skin. The reason that is when implants first came out, now it was probably about 40, 50 years ago, they tried just throwing the implants in right underneath the skin. They said, well, this is awesome. We could take off the breast and just toss it in and close it up. And it didn't work. There was high infection rates, high exposure of implants, because just putting it right under the skin didn't work. So that's when they actually went to, well, let's put it underneath the muscle. And that went well. But the part of the implant that wasn't covered by the muscle, they would still have issues. So they actually started using that same acellular dermal matrix on the lower part of the breast. Well, when that worked well, probably about 8 to 10 years ago, plastic surgeons said, well, if it works well on just the lower portion, why don't we cover the rest of the implant and see if that works? And so what that acellular dermal matrix is that they take human skin from a cadaver and remove it, and then take just the deepest layer. So that's called the dermis. Okay. They then process that dermis so it doesn't have any cells in it. So it's completely acellular. So I tell people that's why it's basically just a sheet of collagen. And what it does is it creates a scaffold that your own tissue grows into that scaffold and just creates a layer between the implant and the skin. So probably today, not over 90% of it implants are placed above that muscle. Well, by placing them above the muscle, what that's mean is it's less painful. So now probably 90% of mastectomies and implant-based reconstruction is done as an outpatient. You get to come in, get it done, and go home the same day. Um, Typically for us to put in that implant, which most of the time I would say is what we call a tissue expander. So it's a temporary implant that has a little port that we can access to adjust the fluid. We can go directly to an implant. I will discuss the advantages and disadvantages of that briefly here in a second. Um, but either way, we wrap that implant with the dermal matrix, put it in to make the breast, close things up. With that being said, it's typically probably 30 minutes to an hour to do 1 to 2 breaths. So it makes it, from our standpoint, from reconstruction, pretty quick and easy. We do have to put a drain in each breast, but then you go home that day, and then typically come back and see us 2 weeks later. When you come back 2 weeks later, typically the drains are ready to come out somewhere about 2 to 3 weeks. We can, if you have an expander, we can add more fluid. When we add more fluid, it typically expands that pocket. So it actually helps us get rid of the drains a little bit sooner. Um, Going through the expanders versus direct to implant. Um, some people like doing the direct to implant because they want to have just one surgery and be done. And I understand that goal of that concept. However, what I tell patients is if we go direct to implant, that means I'm choosing the size of your breast. If we do a tissue expander first, you're choosing the size of your breast. And from my experience, the patients that I've gone direct to implant, most of them, once it's done, say, I think I want to be a little bit bigger, or this needs to be a little bit different. So to me, I don't think it's quite an accurate pitch to say it's one operation and done. I would say the majority of people still get another operation. So from that standpoint, I think you have a better outcome, better long-term outcome if we go the tissue expander first, let you expand it to where you like it, see how you like it, and then go to the implant with that. And so I encourage that, but I still have some patients say, I know I want to be the exact same size. Let's go ahead and do it. And then I would say it's at least 50-50, then maybe even higher that we have to go back and do it again. Um, with doing the implants directly above the muscle and directly underneath the skin. One thing, the advantage of that is it's less painful, so quicker recovery. But also, patients who have implants underneath the muscle, if they exercise, you can see that move. And so people don't like it if they go to a gym and are working out, and people say, "What's going on with your breast?" It's so we call that an animation deformity. So by putting it above the muscle, we don't have that, and it fixes that problem. On the other side, the muscle used to create an additional layer between the implant and the skin. So it basically created a layer between the implant or extra padding. So there's sort of a more of a tissue barrier. Well, without that tissue barrier, now it's very thin what's over the implant. So probably the biggest negative is we see more rippling, or you can say the rippling of the implant. And that's the biggest negative of doing an implant above the muscle. With that being said, we now are doing more fat grafting to try to just create a little bit of padding. And it's amazing how well that works. If you create just a little bit of padding, it tends to hide those ripples very well. That's typically, some people do that at the time that they exchange out the expander and put in the implant. I more commonly wait and do that because I found when I did the fat grafting, I'm guessing where to put it. You don't know where that rippling's going to be. So to me, I would put it in and then I'd be, oh, nope, there's rippling over here. I wish I'd have put it over at this side. I would also say in my practice, I would say it's probably a third of patients have rippling that they want something done to it. 2/3 don't. That if you I typically put in just a tiny bit bigger implant than what we expand to. And by doing that, it's tighter so that you're less likely to see the rippling. So, negative of implants. So the disadvantage of implants are that they're a foreign object. Okay. That foreign object is not dangerous. It doesn't necessarily cause diseases, but we do have issues with it. Okay. Um, Textured implants that we used in the past, about 7 or 8 years ago, was probably the last that they were used, have been related to causing lymphoma. So we don't use textured implants anymore. To be honest, if someone came to me and said, I want you to put in textured implants, I'd tell them you need to go to a different doctor because I won't do that. That doesn't make sense to me. But pretty much right now we do use smooth implants. I will tell you, there is a company out there now that is from Europe that is bringing back textured implants. They're supposedly less texturing, so they say it will not cause that lymphoma. Um, I won't try that until we have multiple years to prove that, because that does not make sense to me. But beyond that, what are the two big problems with implants? The two biggest problems with implants are first infection. And so that's at the time that either the expander is put in or at the time that you exchange out the expander to the implant. And that risk is roughly about 5% of the time. The reason there's a higher risk of infection with implants is because implants don't have blood supply. So our bodies fight infection through the bloodstream. Neutrophils, macrophages, things to attack bacteria. The body's constantly doing that. They say every time you brush your teeth, bacteria gets in the bloodstream. We don't get sick from it because our body fights that because of the blood supply. Well, with implants not having blood supply, there's no way for that to get to it if bacteria gets on the implant. And so that's the biggest issue acutely is infection. If you get an infection with an implant, if it's just in the skin, sometimes we can give an antibiotic and it goes away, and that means the bacteria didn't get into the pocket and it's fine. If it comes back again, it means it's gotten to that pocket and we need to take out the implant, get rid of the infection, and then come back again some other day and do the implants. Um, there are people that try to wash out the pocket, put another implant back in. Sometimes that can be successful, but I would say more often than not, it's about a 50-50 chance that you try that, you're going to be back at the same place again. So, um, second negative about implants is they just don't last forever. They're not permanent. Okay. Our literature says 50% of patients by 10 years have to have their implants replaced. So depending on your age, just means you may have to do this multiple times throughout the rest of your life. Now, that being said, they only have to be replaced if they're causing a problem. So it's not like every 10 years you go to the doctor and say, change my tires, you know? So they only get replaced if they're a problem. So I tell people it's like oil change every 3,000 miles, tire change when the tires go bad. So what's the most common reason that things go bad that you have to change them? The most common reason is a thing called capsular contraction. And what that is every foreign object that's put in the body, breast implant, pacemaker, chemotherapy port, knee implants, because they're a foreign object, your body forms a wall around the implant. That wall is what we call the capsule. 100% of women who have a breast implant have a capsule. Okay. And that could be augmentation or reconstruction. Most everyone, you can't tell it's there. If you can't feel that capsule. However, over time, that capsule can thicken. When it thickens, the body tends to squeeze down around the implant. So the breast becomes tighter, the implants become tighter. When that happens, they can also get hard, so hard that like you can knock on them like that. That's the most common reason we change implants is because that capsule disfigures the breast or makes it uncomfortable, makes it firm. So we go back in through the incision, remove the implant, take out that bad part of the capsule, put a new implant back in. Okay. Um, and so that's the biggest reason to have to change those. Okay. Going through those two disadvantages, risk of infection is 5%. The risk of getting a thickened capsule is about 5 to 10% at 5 years on someone that hasn't had radiation. Okay. If you've had radiation therapy, those numbers go way up. So the risk from 5 goes up to 30% chance of getting an infection. Okay. The risk of capsular contraction goes from 5 to 50%. So in someone who needs radiation therapy after a mastectomy, or say someone that's had a lumpectomy and then has to go and get a mastectomy and they've already had radiation therapy, those are your risks. That 1/3 of patients, if you try to do an implant-based reconstruction after radiation therapy, it's going to fail because you're going to get an infection. If the 2/3 that do make it through, 50% of those get a capsule that can be thickened and hard. For a while, we thought maybe doing the pre-pack and putting that AVM would decrease that 50% number. I don't think there's anyone that's shown in the long term that that's the case. So for radiation, we specifically say tissue is the best option because it doesn't have those problems. All right. So going to the second side, or the third option, I guess, tissue-based reconstruction. So the advantage of tissue-based reconstruction is it's making a breast all out of you that you have for the rest of your life and you never ever need anything done. It permanently makes you a new breast. It's making you a breast out of fat, so fat cells can't become breast cancer. They're fat tissue, not breast tissue. So that's the advantage of the fat is, and we can take that from multiple different areas. We can take it from the abdomen. We can take it from the thighs, sort of the posterior thigh. We can take it from the butt. There's some patients we can take it from the back. And so just basically what's available. The abdomen is the gold standard. That's the best option. It's the best option because it's the softest fat. Excuse me, when we make a breast from abdominal fat, it actually feels like a breast. It's soft. Women's breasts are made of breast tissue and fat. So when you make it from fat, it's very much like that. When we do that, most patients say it feels more natural to them, like running, exercising, doing things like that. It's kind of like back to having themselves again versus having an implant. So that's the advantage of the tissue. What's the disadvantage? Disadvantage, it's a longer operation, longer recovery. Okay. To do the tissue, to make the breast from your abdomen takes me somewhere around 5 hours. Depending on who does it, if you look on the internet, they describe 8 to 10 hours to have that operation done. It means that you're in the hospital 1 to 2 days. When I do it, people do sometimes stay up to 4 or 5 days, depending where they have it done and so forth. So it's definitely longer recovery. Typically when you have that operation done, the abdomen is the worst part. That's where it's the most sore. So I tell people that the abdomen is probably a negative and a positive. I mean, you do have an incision on your abdomen, it goes hip to hip. You're going to be very sore after that operation. Most people don't complain of any chest pain. It's all how sore their abdomen is. It takes a while then for you to get your muscles and strength back and everything after the operation. So the recovery down here is the negative. The positive is you're getting rid of extra fat that's here. So it's like getting a tummy tuck. I tell people the difference is in a tummy tuck, I make the exact same incisions, but with a tummy tuck, I throw the fat in the trash can. Here, I take the fat, move it up, and make a breast. That's the disadvantage, is really the recovery from that standpoint. With using the tissue-based operation, we don't have as much risk of infection because there's blood supply to everything we move up there. In addition, in a radiated field, we're moving tissue that has normal blood supply, so it actually helps the radiated tissue heal because we're improving blood supply. With the tissue, The biggest risk is that when we disconnect it, we have to move the tissue up here and connect blood vessels in the chest. And so I tell people it's sort of advanced plumbing. It's plumbing to bring the blood flow in and plumbing to bring the blood flow out. If that plumbing doesn't work right, then that tissue can die. The chance that that happens is less than 1% of the time. So it's extremely rare that that happens. When we do the operation, you stay in the recovery room for about 4 hours after surgery. And the reason for that is the chance that blood flow is going to stop typically is within the first 6 hours of the surgery of when we connect it. And so by the time we get done connecting the blood vessels, it usually takes us a couple hours to finish closing, plus 4 hours in the recovery room means that we're keeping a close eye on it for that first 6 hours. If there happened to be a question or a problem, they call us and we would come and check it out. So, so those are really the three main options for reconstruction. I think additional topics just to briefly talk about as well that I would say are things that kind of have changed over the past 5 to 10 years. I already went through switching from being below the muscle to being above the muscle. I would also say that more recently we've changed the incisions that are done with mastectomies. Okay, so how the mastectomy is done makes a big difference on what we get from a reconstruction standpoint. The old mastectomy that used to be everyone that had it done had an incision that just went straight across the breast, both sides just straight across. And then we went to doing nipple sparing mastectomies, in which in some patients we could save the nipple, in which we would make an incision, they would carve out the breast tissue, but we'd keep all the skin on the breast. With that, just to let you know, there are kind of 3 incisions that can be done for a nipple sparing. We can do an incision that just goes along the crease. Then we could do a vertical incision, or we could do a lateral incision. Okay, all 3 of those are good options. I would suggest that depending on the size of your breast, that either the vertical or the lateral incision can be a better option based on if you have a larger size. The reason that is that the main blood supply to the nipple comes up through the breast tissue. So when you remove that breast tissue, you're removing the main blood supply. So then the blood supply has to come through the skin. Okay. If you make an incision in the crease here like this, that whole area can't get blood supply to the nipple. So you're basically cutting out a fourth of the area that blood supply can go. Versus if you make an incision straight up, it can still go 360 degrees all the way around. So for a larger breast, doing just a little slit incision, while you may say, oh, I'm not sure if I'd like that scar, it's better to preserve blood supply to the nipple. Okay. Well, once we started doing those incisions in which we're making an up and down incision here or an incision here, we found, well, wait a second, that makes a better scar. And so I would say we've even transitioned now where patients who are having their nipples removed, we're doing more of a vertical scar up and down here, because then if you want to wear a V-neck dress, there's no scar right here. And so in the long run, it's tending to make for better outcomes because we just have an up and down incision. If we do a deep flap, the only circle we make is a circle where the nipple would be. And so when it's all done and healed, if you get a tattoo right there, it looks like the nipple areola. And so it's funny that just going from doing nipple sparing, we've said, well, wait a second, that looks so good. Let's do this. And so it's just little things to help improve the appearance and shape and so forth. So.
Awesome.
It's
Yeah.
very thorough.
Yeah, thank you.
We do have a couple of questions that I think that we'll cover as a group, if that's okay.
Perfect.
And then,
Perfect. You want me to go through these?
yeah, let's see what is on there that
Alrighty.
would be
I can do
applicable.
this. All right, so the first question that's on here says nipple reconstruction, long-term pros and cons with the nipple tattoo.
So
So,
making a mound
sure.
or in the,
Right. So what I would say with nipple reconstruction, that's another area that has improved greatly probably in the past 10 years. Okay. Mainly not the nipple reconstruction itself, but the tattooing it's night and day difference than it was 10 years ago. There's some amazing medical grade tattoo artists out there even that from across the room, you couldn't even tell looking at them. So what the two options are there is one, we can take the tissue and what I would tell people is basically skin origami. Is take the tissue and fold it on itself to make a nipple that sticks out. So the way that we kind of do that is if the tissue's laying down like this, we cut around the tissue like my hands and lift it up like this, and then bring the tips together and put a cap on top. So it's just using all the skin right there to sort of bring it to make a nipple that sticks out. In my experience, I would say at least 50% of women who get bilateral mastectomies decide they do not want a nipple. Okay. And they say they do not want a nipple because they don't wear bras anymore. And they say, well, if I have a nipple, then I have to wear a bra to cover it up. And they're like, I am so much more comfortable that if I don't want to wear a bra, I don't have to. I don't want a nipple. And so then they just go and get the second option is just to get a three-dimensional tattoo. Okay. Then there's some patients that don't get either one. A couple patients have informed me that if you go on Amazon.com, they actually sell temporary nipple areolar tattoos. And so you can try that out first. And if that's something you like, then I would recommend getting the three-dimensional tattoos. The only thing I tell people is to make sure you measure what width you want. Because a couple people did it and they said they were way too small. And they said, I liked how it looked, but it just wasn't proportional to my chest. So, I don't know of any like negatives from a health standpoint with the tattoos. So, it's all very safe. My office at one time, we offered the tattooing in our office and we stopped doing it because it was so inferior to what you can get by getting a professional done. We're like, this doesn't make sense. We're offering substandard care. Why would we ever do that?
well, and we'll mention too, because we've actually had sessions with Haley with Healing Arts Studio in Charlotte, and she expressed to us that it's actually more challenging for an artist to make a 3D nipple if there is a mount.
I bet it is.
So she said, we can really, it's easier to work with a smooth
Sure.
canvas than it is to try
I bet
to
it is.
add dimension to something that's there. So that's just something.
No, I believe that. And
Yeah.
I actually tell people it's a very personal choice.
For sure.
Because there are some patients that, like, I actually had a patient I saw today who she's just had her nipple made, has not had the tattoo. And she came in and said to me, I am so thrilled and so happy now. She goes, before this, I felt like I was disfigured and I was like, what has he done to me? What's going on? And as soon as I had that done, she said, okay, I have a breast. And so there's some patients that just getting that
Yeah.
transforms it into, oh my goodness, I have a breast again.
Sure.
And so it's a very personal thing.
Another question we wanted to ask about, so we have a patient that is in treatment. She currently has expanders and is planning to do a deep reconstruction after treatment. She does have diabetes.
Mhm.
Can you talk a little bit about just the
Sure.
process and things to keep in mind in that?
Sure. So I would say that there's a little bit increased chance of wound healing issues with diabetes, but it's not a big deal. Like to me, if you have diabetes, it doesn't change anything for me doing the operation.
Okay.
For
someone that does have diabetes, is implants an option or is deep the recommended?
No, I would say you could do either one.
Okay.
I would definitely say you could do either one. Yes, I think it's definitely a choice there.
Okay.
Yeah, and I can't say that I've seen anything that there's an increased risk of infection or problems with diabetes with implants. I would anticipate that if you were a poorly controlled diabetic, that could be an issue, but otherwise, no. I would have no issues with doing implant or tissue with diabetes. So, all right, hard lumps where fat is transferred. What is that and how to make it better? Okay, so I guess there's two considerations when fat is transferred there. So I guess if you have a deep flap done and you have some hard areas after the deep flap, what that is, that those are fat cells that have died because they didn't get enough blood supply. Okay. The tissue that we take from here and move up to here, I tell people it's kind of like a tree in which the trunk of the tree is the blood vessels that go in. So the artery that goes in and the vein comes out, and they go up into the middle of that tissue that we move. The middle is then where all the branches and the leaves of a tree. Okay. And so they branch out like in multiple different areas. Well, sometimes those branches don't get all the way to that very end of the tissue that we've moved up there. And so some of the fat cells on the periphery, for the most part, may not have good blood supply, and that's where the tissue can die. Or if you think about the tissue that we remove, if we're taking half of your abdomen, the tissue that's all the way the farthest away from over here, sometimes that tissue out there doesn't have good blood supply. And so if it doesn't have good blood supply, then it dies, and then that's what we call fat necrosis. It's not something that will keep happening. So it's not like, well, if you go in and cut that out, am I going to get other areas and the fat is just going to keep dying? No, it's strictly from the original transfer. And so it's not uncommon. There's sometimes that people have a little bit, we go in and take it out and then it's done. It won't come back again. And so that's hard areas from that. Now, when you
Is
do
massaging or anything you can do to get rid of that, or is it only surgical? Will the body eventually, will it just?
So the body can absorb it, some of it. And sometimes right after surgery, there's an area that feels firm, that may be just edema within that tissue. And once the edema goes by, it feels very soft. Or there's an area where there is some fat necrosis, but there's edema around it because your body's cells are trying to take care of it. That once that goes away, you're like, well, you felt like it was this big and now it's this small. Well, originally that small area was the only area that died. So one, massaging it, that can help, because it can help get rid of the edema and can help the cells sometimes get rid of those dead fat cells. I will say also that I will occasionally at times try to inject steroids into those fat cells that have died. Because once the fat cells die and the body gets rid of that, then sometimes it makes scar around that area. And so for patients who have like thickened scars or keloids, we'll inject steroids to try to break up that scar. So I'll actually inject steroids into the scar on the inside. And there are some patients that works very, very well. That doing that injection can actually get rid of that scar tissue. I've had patients that ones that like 100% eliminated it. I would say for most everyone, it will shrink it and make it smaller, and then we can evaluate what to do at that point. The second fat transfer would be if you get fat grafting, okay? And so you can get some fat necrosis with fat grafting too, okay? When we do fat grafting, we liposuction fat from some part of your body and then inject it. So like I discussed, for people that have rippling with their implants, fat grafting can help fix that. The key with fat grafting is that we're injecting fat cells or fat globules that have no blood supply. So they have to be surrounded by your normal tissue to get blood supply to live. So when we inject the fat, we'll inject it, say like my fingers, in which this is an injection, but this is your normal tissue that's surrounding it to make sure it has blood supply so it doesn't die and we don't get that necrosis. And so what we try to do is inject it kind of in layers, trying to make sure that we maintain blood supply. That's the reason why we couldn't just make a whole breast by doing fat grafting. Okay, because if you took a breast like this and I injected a big ball of fat, only the areas on the outside are getting blood supply. Everything on the inside can't get any blood supply. So then you get this hard, you know, tennis ball size of just dead fat in there that will be hard as a rock. So those little things, it's possible that we could try injecting steroids to see if it helps. Usually those are small enough that over time, if you massage them, they can get better.
Yeah, I'll just ask, what would make you not a candidate for DEEP?
Okay, one, if you've ever had an abdominoplasty. So if you've had an abdominoplasty, that tissue's been used, it's gone, okay? People who've had liposuction would be a relative contraindication. It just depends on how much liposuction they've had there. Honestly, you'd have to have very aggressive liposuctioning for it to not work. So I would say cosmetic liposuctioning to where they've basically taken most everything. And then the third thing would be is just how big do you want to be? So I've done deep flaps on patients that weighed 120 pounds. And so their breast, when they had their mastectomy, was only 125 grams. And then I did a deep flap and put up 120 grams. So they were an A size breast before and A size breast afterwards, and they're happy. But
I guess this is why I'm a double D then.
Alloderm
So ADM what is the difference between ADM and alloderm?
is an ADM.
It is, okay,
Yes, so there are multiple companies out there that make ADM.
okay,
So it's Alloderm is an acellular dermal matrix.
okay,
And so there's Alloderm, there's Dermacell, there used to be a thing called Allomax. Pretty much there's probably a half dozen companies out there that sell acellular dermal matrices.
okay.
Alloderm is probably the most common one used in the country.
Okay, and then one more, I do have like 800, but one more that I think would be good is if someone has had radiation, because I know you spoke a little bit about that and the skin condition, but if someone has had radiation, what would the recommendation from a, cosmetic, just how that skin is versus someone who hasn't had radiation, what would be your recommendation for surgery?
So what happens when you have radiation, it causes microscopic scarring throughout the tissue, okay? Everyone responds to some degree differently from radiation. There are patients I've seen that have radiation, I couldn't tell they ever had it done. Looks completely normal. On the other side of the coin, I see patients that have radiation therapy that their skin is as firm and as hard as a leather bag. It's absolutely awful, okay? The National Cancer Guidelines actually say that if you're going to have reconstruction, that tissue is the best option for that. That being said, as I stated, not everyone is the best candidate to use tissue. I mean, if you're a D-sized breast and you weigh 130 pounds, there's no way there's enough tissue to do that. In that case, there are patients that we try to do implants, but like I said, it's a 30% chance of failure. If that fails, we're still going to have to bring in some sort of tissue to do the reconstruction. And what that means is we could still do a deep flap, move that tissue up, get some healthy tissue with good blood supply, and put an implant underneath of that. Okay? If when we do that, it changes the risk of failure of that implant from that 30% back down to the normal 5%. Because now the implant's covered by your normal tissue, it's not covered by radiated tissue. And so I know some people that are actually part of NothingPink that we've actually had to do that for. So I won't share that. But if you didn't do a deep flap, another option would be to take tissue from the back and move that around to the front to just get that implant covered by healthy tissue that has good blood supply. So.
Yeah.
Thank you. Okay, so I'm gonna end the recording. Thank you, Dr. Robinson.
Questions on
Yeah, let's see.
Is it possible for me to come watch a surgery? Am I allowed? What setting?